So good morning, everyone. It's my pleasure to introduce shortly Janina Eden. She is a resident in our department. She will present the second part of the talk on modern therapeutic approaches for liver tumors. Last week we heard everything about resections and ablation treatment, and I think today we will hear everything on liver transplantation in terms of liver tumors. Please, Janina.
Thank you, Professor Dudkowski. Today, we want to focus on liver transplantation in comparison to last time where we focused on ablative and surgical therapies for malignant liver tumors. Again, the entire presentation is based on this paper that was published by Professor Petrovsky and Dr. De Oliveira and Professor Dudkowski and our chief, Professor Clavier. Again, we will cover the same tumors we talked about last time, the HCC, the PHC, the ICC, colorectal liver metastases, and NET metastases. Let's start with the hepatocellular carcinoma first. As you know from the last presentation, the HCC is the most frequent primary liver malignancy, and there is a 1 to 5% yearly incidence in cirrhotics. Now, the challenge we're facing is the poor liver reserve due to the underlying disease and the vascular invasion, which is very common for this type of tumor. And that makes surgical resection possible in only 20 to 30%. Another challenge is the risk of tumor recurrence, which is quite high at 80% at 5 years. So last time I showed you a lot of advanced surgical procedures, but there still is a high recurrence rate because we don't treat the underlying disease. So the most logical thing to do is to just exchange the entire liver. And by doing that, we would not only cure the multifocal diseases, it would also serve as the best oncological resection. We would cure the cirrhosis, and with all of that together, restore normal hepatic function. But there is a downside to this procedure. One, the immunosuppressive treatment. If we downregulate the immune system of the patient, then the risk for recurrence increases, and also the risk for secondary tumors to occur. And then also the waiting time is a problem. It's not unusual for these patients to have to wait for a couple of months up to a year to come to our department. So what are the risk factors for tumor recurrence after liver transplantation? There are donor-related risk factors. There are recipient-related risk factors, and tumor biology needs to be taken into account as well. When we talk about donor-related risk factors, there is one, the donor age, there is steatosis, and then there is ischemia as part of the reperfusion injury. And then the recipient-related risk factors are tumor size and number, together the tumor burden, the AFP value, if it's high, then that's an indicator for systemic tumor spread, and then there are certain inflammatory markers. As for tumor biology, vascular invasion, tumor differentiation, so low differentiation, high-grade tumors, and a certain gene signature will or can lead to tumor recurrence. So the idea of transplanting patients with HCC is not new. In fact, it's been on the map for over 30 years, and it has been tried, and the results were quite bad. And so a surgeon from Italy, Milan, Dr. Mazzaferro, decided that a better selection would be necessary of these patients. So he decided to only include patients for transplantation who had one lesion that was smaller than 5 centimeters, up to 3 lesions smaller than 3 centimeters, no extrahepatic manifestation, and no vascular invasion. But with that, the survival rates increased by quite a bit, 75% 5-year survival rates and 10% recurrence rates only. Now, the question is, are these criteria too restrictive? Because many of our patients have tumors much larger than those 5 centimeters and more lesions than just those 3 lesions. So I wanted to show you one case of a patient, male, 60 years old. Hepatitis C is an underlying disease, largest tumor, 7.5 centimeters. And what you can see on the left side is that we have a cirrhotic liver, which is small and disfigured. We have a large spleen, about double the size of the actual spleen, which is a sign for portal hypertension. So what do we do with a patient like that? Clearly, he's not a candidate for resection because of the underlying disease, but he's also outside Milan. So you get the problem we are facing. So, and many surgeons around the world noticed the exact same problem, and that is why an extension of the criteria seemed necessary. So, model by model, as you can see, size and number increased. And of course, there is a question, well, what happens to the survival rates? Do they drop significantly or don't they? And in fact, they do drop a little bit, but not as much as you would expect. In fact, there is still an overall 5-year survival of over 60%. And even when you do not limit size and number anymore. What's also important is that there is no consensus on which model to use. And that is the main question. Which model is the best one? There are so many, so which one do we choose? Every center has different approaches, not only in Switzerland, but actually Europe-wide, worldwide. So in Geneva, for example, they use the TTV model. In Bern, they use UCSF. In Germany, they use Milan only. And we use the Metroticket 2.0 model. Again, Mazzaferro, you know him, he invented the Milan model. He invented another model, which is called the Metroticket 2.0, and that is a combination of size, number, and the AFP. Now, if you look at the right-hand side, marked in orange, if you have 3 tumors with the largest nodule being 2.9 centimeters and a high AFP, moderately high, 240, then you get a 5-year survival rate of 85%. Now, if you only have 1 tumor, larger diameter but low AFP, you get a 5-year survival rate of 95%. So the AFP seems to play an important role. And now you might ask yourself, well, how good is this model? There are so many models, so how do we know that this is a good model? Because of the Herald C index, which is a quality of prediction. And the closer it gets to 1, the better the model. Now, in this model, we have a Herald C index of 0.7. In comparison to that, we have a Herald C index of 0.6 for the Milan model. So to answer that question, yes, it in fact is a good model. And you might think it's complex to use, but it's not at all. If you look it up online, that's exactly what you will find. And you just have to adjust your size of the largest vital tumor, your number of vital nodules, and your AFP. You press calculate, and then you get your 5-year survival rate. So really easy to use as well. Now, some more examples. Case number 2, HCC, NASH, underlying disease, and the tumor is very large, double the size of what Milan would accept. And it's non-resectable, and it's a singular lesion. Now, we have a low AFP, no extrahepatic disease. And the estimated 5-year survival rate, if you use a Metroticket, would be 75%. So what do we do with this patient? We transplant. Now, on the contrary, if you have this patient, tumor not as large, 8.2 centimeters, AFP very high, the Metroticket tells you that there is a lower than 10% 5-year survival rate. So we would never transplant a patient like that. But not every case is as black and white as the previous ones. If you look at this case, 69-year-old male, NASH is an underlying disease, HCC, tumor, largest diameter, 6.4 centimeters, high AFP. What you see, or what you should know, is that this tumor is initially resectable. But we decided against resecting right away. What we wanted to do is to evaluate the biological behavior of the tumor, to get to know the tumor better, to see if that tumor would react to treatment, to see which treatment eventually will be the best one. We did the TACE procedure 1 month after a diagnosis. TACE is transarterial chemoembolization, which is directed, located chemotherapy targeted at the tumor only. And by doing that, the initially very high AFP levels dropped down from 65,000 to 209. So the tumor responded very well to the treatment. And when you look at the Metroticket down below, the actual estimated survival rate was now 62% at 5 years. So he would have been a candidate for transplantation. We decided against transplantation in this case because of 3 reasons. 1, the tumor was initially resectable, and it was a peripheral location, so we could resect the tumor. 2, the underlying disease was not as bad as it could be. It was a low-grade NASH, so if we would resect the tumor, future liver remnant would be sufficient. And 3, the waiting time. Because of the really high AFP levels, we suspected that there might be recurrence very soon if we would transplant. And so we decided, because of the waiting time, because of the high AFP, and because of the other mentioned reason, to go for resection instead of transplantation. And surprisingly, the histological results after resection, only 0.7 vital tumor was left in the resection specimen. And that was other than expected. We thought it would be larger than that. That's what TACE can do. Now, what do we do with these patients after we resect them? We're not done because we have to see what happens next. So there are 2 pathways, actually. One is to do the resection, to list that's on the left-hand side, sorry. So when we do the resection, we list that patient for transplantation right away. That's called bridging, and then we wait for the organ to arrive. Now, there are 2 problems with that. One, the waiting time. Remember that patient had a high AFP, so a recurrence could just as well happen during that period of time. So that's a problem. And 2, if something goes wrong with the transplantation, everyone is going to ask us, why did you transplant that patient? Because that patient does not have a tumor anymore, and we will still transplant that patient. So there will be criticism, or there can be criticism, and that's what we have to live with then. And the second option is to wait after resection for a tumor recurrence to occur. Problem with that might be that because of the high AFP levels, if a tumor recurrence eventually happens and we see it on scans, it might be too late already because systemic spread has happened. So maybe there are bone lesions, and with that, the salvage procedure can never take place anymore because that patient is palliative. So there is a controversy. And now, of course, the main question remains, what is better, transplantation, resection? What do we do in these patients? And it's not really that easy to answer because we don't have RCTs on this matter. And RCTs would be gold standard. There have been several attempts to try and to create the ideal meta-analysis, such as this one. It's not a meta-analysis. It's just a sum of retrospective studies, really. Still, I wanted to show you the results. 3-year disease-free survival of 54% for liver resection in comparison to that 74% for liver transplantation. Quite good, but if you look at the results closer in the chart down below, and I don't even think you can read that very well, but basically what it says is that the survival is significantly higher for liver transplantation only at 10 years. And so we have to get these patients to this 10-year mark. And we don't get all of these patients to this 10-year mark. So I think we're aware that we need more data. That's the key message. So perihyalocholangiocarcinoma, clad skin tumor, better known as that. The main problem with that kind of tumor is the problem to resect it. Because it is located in the middle of the liver, very central, so resection oftentimes proves difficult. And because of that, people around the world for a long time thought about transplanting these patients. So again, not a new idea. And it has been done, but the results were equally bad. And the 5-year survival rate was only between 21 and 36%, between 93 and 2001. And that are the US results. In Europe, not much better, same results. Now, in 2002, the University of Nebraska introduced routine neoadjuvant therapy prior to liver transplantation. And that became part of the Mayo Protocol. And the Mayo Protocol is nothing more than a strict selection of patients. Upper tumor size 3 centimeters, negative lymph nodes, no intra and extrahepatic metastases, external beam radiation, and chemotherapy. Now, when that was established, the results were staggering in comparison to before. Now, 1-year results, overall survival, 92%. 3-year survival, 82%. 5-year survival, 82%. So almost too good to be true, and I'll get to that in a minute. Let's go over the Mayo Protocol one last time because it is important. Unresectable PHC, then negative lymph nodes. You do your neoadjuvant chemoradiotherapy protocol. You follow the Mayo protocol. Then you do your scans, see if there's disease progression. If there's disease progression, protocol aborted. If there is no disease progression, you do your staging laparotomy. Then you can go ahead to your liver transplantation. In 2009, because of those really good results, the UNOS decided to give MELD score exception points for patients with PHC and completed neoadjuvant therapy. And they were set equal to scores for HCC. And that is a huge improvement as it leads to those patients getting organs quicker. And in those results, the good results still were not believed by many people around the world, many surgeons around the world. And because of that, Murad et al. Decided in 2012 to do not a single center study, but a multi-center study. The last one was a single center study. And they got equally good results, 65% 5-year survival. So if you look at the data, and that is the data, if you stay inside Mayo, you definitely have a better recurrence-free survival. And if you have small tumors, you also have a better survival. And that is basically staying inside Mayo. Now, the shortcomings of this study, and that's what critics voiced, is that the tumor was not always confirmed one. So we don't do biopsies on these tumors. So we don't know if that actually was a tumor or not. It could have been something entirely different. And then the main criticism towards these studies were that the selection bias, because we select these patients highly. We use the Mayo protocol. So maybe the good results were just because of that. And because of that, another doctor, Etun and colleagues, doctors, decided to do another study. 10 academic US institutions this time, and this time they compared transplantation and resection. And what they found is that transplant in all patients included, was better than resection. And it was also better in lymph node negative and small tumors. So because of all of what we just heard, because of all of the results, liver transplantation is indeed in the treatment pathway for perihilar cholangiocarcinomas. So it is implemented. But we don't have enough data yet. So currently there are 3 RCTs on the way, 2 in Norway, I think, and 1 in France, and we are impatiently waiting for the results. And one last case, case number 5, 45-year-old male, unresectable Klatskin tumor, combined radiochemotherapy, so we did follow the Mayo protocol. And that patient we were able to transplant. The donor was perfect, for that matter, perfect velometry, biopsy good, normal anatomic function, good graft volume and function. And up to this point, this is, I think we followed them for 14 years. 14-year follow-up. Donor and recipient are fine. No recurrence. Now, let's talk about the intrahepatic cholangiocarcinoma. The problem with that tumor is those tumors are oftentimes very large, not because they're like that right away, but because these patients, when they come to our clinic, they often present late because they don't have liver-specific or oftentimes show no liver-specific symptoms. So when they come, it oftentimes is at a later stage. And that's why the tumors are quite large, and that's why resection proves difficult. And if you look at the treatment pathway for those intrahepatic cholangiocarcinoma, what you will find is that transplantation is not even in there. It's not even mentioned. So is it an option or is it not? The fact is these patients do come to our clinic. They exist. So what do we do with them? Do we just wait? Do we do something else? Do we do transplant? Do we do surgery? What do we do? So, and they're not that old. 45-year-old female, in this case, number 6, intrahepatic cholangiocarcinoma. And what's important and what is almost always the case is that these patients, and this is pretty much unreadable, I don't want you to read it, I just want you to get the idea that these patients usually undergo a series of diagnostics and treatments before we even consider them for liver transplantation. So in this patient, she had chemotherapy, other ablative therapies, and so on and so on. And eventually, we will discuss them in the tumor board. Eventually, they will be discussed with the question of transplantation. And as you can see, we sometimes even ask other surgeons what their opinion on this case is, and there really isn't always consensus. It's not a black and white case at all, ever. So in this patient, we did liver transplantation eventually. Now, another case, 60-year-old male, PET-CT negative. We discussed that patient in the tumor board as well. We decided to do chemotherapy first, systemic, and we implanted the IHA pump. We did systemic treatment, chemotherapy. We did, again, a tumor board discussion. No indication for transplantation at that point of time, so further chemotherapy. And then we looked at the scans and we saw only partial response. And therefore, we kept going. Chemotherapy, SEER procedure, then complications, cholangitis. We did an ERCP, put in stents, did a PET-CT eventually to evaluate non-knife indication as a bridging to liver transplantation. And we saw the tumor is still there, PET positive, but it's smaller than 2 centimeters. And I need you to remember the 2 centimeter mark. So we went ahead, did our explorative laparotomy, did our lymphadenectomy, which was negative, luckily, and we did our non-knife procedure. And then we transplanted the patient. So after years, we decided to do the transplant. So this time used a living donor, the daughter of the patient, 30 years old, used the right lobe, did a aortic hepatic conduit. That's how it looked like before we implanted. And the postoperative histology, again, very surprising. Small tumor volume, only 0.12 millimeters left. And we suspected it to be much bigger on scans. So that is surprising again. Now, the message is that only very small tumors, after often many rounds of multimodal therapies that are smaller than 2 centimeters, do have a lower risk of recurrence and increased survival rates after transplantation. And I think what is important, what you need to remember is bridging is key. This is not an upfront transplantation, but there is a multimodal approach that needs to be done before even considering them. Oh, and those are a recipient and a donor, and they're well. Both of them are well, no sign for recurrence. Currently, 4.5-year follow-up. Now, let's talk about colorectal metastases. Main problem with these tumors is the high recurrence rates. So, if you look at this case, 37-year-old female, synchronous bilobar colorectal liver metastases, primary to the colon, initially not even that large, but metastasized extensively. So what do we do with these patients? Well, again, multimodal therapy is key. And transplantation is not first choice. So we did a lot of things with this patient. Chemotherapy first, then we did a wedge resection, then we did the ALPS procedure, again chemotherapy, then we tackled the primary, then we did a non-knife procedure, and then again chemotherapy. And only because there was excellent response and no extrahepatic tumor with very few remaining lesions that were PET negative, we considered that patient for transplant. So we did our staging laparotomy to exclude extrahepatic tumor, which luckily there wasn't. And then we did a living donor transplantation. This time it was the husband. We used the right hemiliver, including the MHV. And interesting, again, the explant histology, scar tissue was seen, but microscopically no evidence of tumor. But make no mistake, H and E, no evidence, but tumor cells did remain in CDX2 staining. So this is a very persistent tumor. This is a tumor that is really hard to get rid of. And currently, luckily, this patient has a recurrence-free follow-up of currently 3 years. So to sum it up, for this kind of tumor, the overall survival is good. And that is because even if tumor recurrence happens, there are still options we have to treat the tumor again and again and again. So there's options like ablative therapies or resection again, because there's no underlying disease in these patients. Oftentimes there is no cirrhosis, so they have more capacity. The disease-free survival, though, is bad. And that is why these patients as well need to be selected very carefully as well. Exclusion criteria: tumor size over 5.5, CE level over 80, less than 2 years time between the CRC and the liver transplantation, progressive disease under chemotherapy, and a BRAF mutation because of the dire prognosis. And inclusion criteria, of course, the exact opposite. And also here, data is key. Currently 3 RCTs on the way: Toronto 1 and Norway 2. And then there are certain novel strategies for colorectal liver metastases. And I want to talk about the rapid procedure for a second. This procedure has been described by Line et al. In 2015 and has been published in the Annals of Surgery. And at the time of transplantation, what we do is the segments 1 to 3 are resected in the recipient, and they're orthotopically replaced by segment 2 to 3 allograft. And then we modulate the portal inflow by redirecting the portal flow to the graft with concomitant focus on keeping the portal vein pressure below 20. And then a second stage hepatectomy is performed as soon as the graft has regenerated to a sufficient volume. And this might be a solution to the organ shortage we're facing, simply because we don't need such a large graft and can use smaller grafts. Now, last but not least, net liver metastases. If you remember back from the last presentation, those tumors show usually an indolent course. And because of that, indication for resection and transplantation is very restrictive. And when you look at the data, they're not promising at all. Resection is definitely better than transplant. So nonetheless, we have to say that there is evidence that if you only choose highly selected patients, that there might be a survival benefit for transplant patients, but sufficient data is currently lacking, and so a definite conclusion is not possible. Let's sum it all up. Hepatocellular carcinoma. Recurrence-free survival, 70 to 80%. Clearly a yes for upfront transplantation, so transplantation right away without any multimodal approaches. Might be, but don't have to because of the good results. Now, perihilar cholangiocarcinoma. Also, recurrence-free survival is not bad at all, but the prerequisite is that we follow the Mayo protocol, so strict selection. As for intrahepatic cholangiocarcinoma, multimodal treatment and bridging is key. So results not as good as the previous ones, but still not all that bad. But again, data also is lacking. So this is a gray zone. And then as for colorectal liver metastases, not very good recurrence-free survival, but very good overall survival. So it's not first choice, but after multimodal treatment, it can become first choice actually. And as for neuroendocrine metastases, only second choice. We don't have data. We cannot definitely say if it's a good idea to do that. So what's the conclusion? There's definitely a need for better knowledge of biological behavior of tumors. And multimodal approaches combining, chemotherapy, ablative techniques, and all of that are needed. And liver transplantation needs or can only or should only be done within well-defined thresholds. And that's why those criteria exist, the Metra ticket, the Milan criteria. Which one to choose? Questionable. All right, so that was it. Thank you so much.
Thank you very much. Excellent presentation. You almost say everything and summarize very well this review that we did here with also other people from oncology and radiation therapy. What's interesting here in the history, at the beginning in the 80s, the main indication was tumors because there was no cirrhosis, surgery was a little bit easier. And then it was abandoned because the result was terrible. I mean, no patient basically will survive more than a few months or at best a few years. And then came in the 90s, the HCC, etc. And many of us, we believe that we would transplant more and more patients with cancer. That may become one of the main indication, and you very well here demonstrated the different indication. Maybe just the HCC, you did very well, many publication, many proposal, still an ongoing discussion. The one thing that everybody want to target is microvascular invasion, right? This is the biology behavior, and we cannot do it just by a biopsy. This or some may attempted, and all the alpha-fetoprotein, etc. So there's many factors. What's important in a country is that everybody need to agree because you share the organ. That's the issue. We cannot just do what we want, another one, and sometimes it's easier maybe in a smaller place than bigger place when there are many centers to agree. And what we have learned today, what we do is a downstaging, as you show very well. If you have a big tumor, we can get down. What is unclear is that really the downstaging that's effective, or is the natural history? What we learn also in tumors, the natural studies say everything. These cholangio that you show were treated over years. Where the treatment really useful? Possibly, because we can keep the tumors, but the biology was probably not bad with no lymph node, and we get the best result. That also explain some of the paper on the fast-tracked transplant, living donor in HCC, where a long time people believed that living donor was bad because of regeneration. It's nothing to do with that, just they were transplanted too early, we don't know the natural history, and then they will develop further. So that's just a comment. Again, you covered that extremely well, and I don't know if there's any question or comment. Congratulate Professor Dudkowski also to assist here.
I would like to ask something. I have a microphone. I'm connected. Janina, great talk. Thank you very much. You said a lot about using living donor liver grafts, which is logical because they are available after, let's say, Mayo protocol or after the TACE procedure. Do you think it is also possible to use different kind of grafts? What do you think? Should we use DCD, for example? We use routinely DCD grafts for HCC patients. Does that make sense in your opinion? Or should we also use split grafts or ECD grafts, extended criteria donors? What do you think about that?
Well, if we can use living donors, then I would definitely go for living donors because we don't have that waiting period. And so the risk of recurrence wouldn't be as high. If we have to use DCD and DBD organs, I think pre-treatment of these organs to not get that reperfusion, the injury and the ischemia and all of that, we would have to use pre-treatment as perfusion techniques, for example.
Okay, yeah, that's what we're actually doing, and it's unclear which perfusion technique, but we have, unfortunately, relatively small number of living donors in Zurich, and therefore we go for DCD grafts and even ECD grafts rejected by others, and we pre-treat them by machine perfusion techniques and hope that this is possible. The data, as far as I understand that at the moment are pretty good, but that is something which need to be considered if we transplant tumor patients. Thank you.
Maybe just the last point that what we have here, many centers, an important factor is to have both liver transplant and HPB in the same team, which is often not the case in many hospitals, particularly in the United States, where there are two separate teams or they do only one. But whatever the scenario, it's very important when you discuss these cases that the liver transplant surgeon is also part of it, which is not always the case. Okay, well, thank you very much. Thank you.
Okay.